The last piece that we're going to do is our immune deficiency diseases. These are actually rather straightforward, guys. We're going to make it very simplistic. We're going to talk about primary and secondary. So primary is going to be up first. These are usually considered congenital. In other words, you're born with them. It's coded in your genes. They're usually heritable. They don't necessarily always follow Mendelian genetics, but there is a genetic distribution. If it runs in your family, it's more likely that you're going to be exposed to this, okay, or have the risk of having a primary immune deficiency disease. The next category that we'll talk about is secondary, and these are acquired, meaning that you have to come in contact with them. And the example that we'll use in the second one is HIV. Okay? So, busy slide, but we'll go through it very, very systematically, and it actually is rather quick. These deficiency disorders, if you look, here's a stem cell at the top coming in the bone marrow, or out of the bone marrow, excuse me. Right? And as it comes out of the bone marrow, it sort of becomes immunocompetent in the bone marrow and makes B cells. Well, from the bone marrow, it also makes the T cell population. Remember we said the bone marrow gives rise to both B and T cells, but the T cells go to a secondary tissue like the thymus to become immunologically educated. Whereas B cells do that in the bone marrow. So the organization of the slide should actually make sense. That T cells come out of the bone marrow and B cells come out of the bone marrow, but they become more immunologically educated in the bone marrow with B cells. And these guys, you could circle these and say thymus. Okay? We've got single gene defects. If you look carefully, you'll see these red squiggly lines. Right? Here's a red squiggly line here. These are all places that we've identified in the literature that have mutations, single gene mutations. We're not going to cover all of them. We're just going to cover a few. In fact, I'm going to give you like one of each. That's it. Fair? Okay. We're going to talk about B cell single gene defects, T cell single gene defects, and then we'll talk about both that affects both. And we won't cover a complement defect or a phagocyte defect, but they do exist. Okay? So first up is a B cell example. So if I back up, where am I on this chart? I'm actually just right here. So if I zoom in right there, you can see I've truncated the slide, and here we're coming down from the stem cell, we're coming down to a pro-B cell to a pre-B cell, and here we've got a defect that we call Bruton disease. It's X-linked agammaglobulinemia. Easier to say Bruton disease. I'd probably put both on the exam for you. Okay, we'll be nice in that way. So if you have a defect here, you don't make any or you make very few B cells. And you don't make any or very few plasma cells. But you have a completely normal T cell response. Okay, so if they don't make mature B cells, one of the problems is because the heavy chain is made, but the light chain is not. So even if they have B cells that are there, they don't differentiate to be able to crank out functional antibodies. They have a normal T cell response. Next up. Selective IGA deficiency. So this is further down on the chain, right here. So I kind of fit. I said I'd give you one of each. I'll give you two of these. The way I'm giving you this one is because this is actually an IGA deficiency, This is the most common primary deficiency that we see. And if you don't make IgA, you can see we're further down in the chain. So all this is made, right? You make your immature B cell, and it gives rise to mature B cells that manufacture M, G, A, and E. But if you lose this one, you don't differentiate and manufacture a mature B cell that makes IgA. So IgA is usually found in blood and on body secretions. So you don't have IgA in blood or in body secretions. And a lot of times you get a lot of recurrent infections in these patients. A lot of recurrent infections. Next up, T cell. So I backed up along the other side of the chart. The T cell one that we're going to highlight is called the DeGeorge Syndrome. The DeGeorge Syndrome. We're skipping a few. You can see what we're skipping. But on the DeGeorge Syndrome, there's a development disorder where the patient doesn't have a thymus, or it doesn't have a full thymus. And if they lack a thymus, then they have an immunocompromised thymus, and they don't make functional T cells. Okay? DeGeorge Syndrome, this one was discovered by an endocrinologist named Angela DeGeorge. It was discovered in, just for your information, 1968. So it's an older known disorder, and it still kind of is in the literature. Okay, then the last one of primary that we're going to look at is actually combined. It's both B and T cell. If you go further up, you can see right here this ADA deficiency. This ADA deficiency is also referred to as adenosine deaminase deficiency, or what we refer to as severe combined immunodeficiency, SCID. So this is where you're so far up here, right? You don't make any lineages of B or T cells. You have no B or T cells. Inflammation is totally normal, right? Inflammation, you can still make an inflammatory response, but these patients are extremely susceptible to just about every type of infection you can imagine. It's called the bubble boy disease, if you've heard about that. It's, they're very vulnerable, these patients, to infectious diseases, so they have to live really in a sterile environment, like in a bubble. Usually they're in a hospital setting for most of their life. David Vedder was the name of sort of a popularized SCID patient or ADA deficient patient, like in the 80s and the 90s, and that was like the original bubble boy that was on TV. I don't know if you've heard about that. Okay, so they are almost completely immunocompromised, these patients. Okay, secondary, totally different. Causes though: malnutrition, stress, cancer. Iatrogenic causes like bone marrow suppression or infection. So secondary are acquired. It's another name for them, acquired. Malnutrition. For example, if you have low levels of zinc in your diet, zinc is important for B and T cell maturation. So zinc deficiencies may actually cause a stress on the level of functional B and T lymphocytes that you have. Stress. Stress causes an increase in glucocorticoids. They suppress the immune system. Cancer. Cancer can deplete functional lymphocytes, especially if it's a lymphoma. Iatrogenic causes, that's a word, it's a fancy word that means adverse side effects. So it means you do one thing, and this is one of the side effects as a result of it. So, for example, bone marrow suppression. Well, in a lot of cancer patients, if you give them aggressive chemotherapy or radiation therapy, you actually kill a lot of bone marrow itself. Okay? And then they become immunocompromised. And then infection, probably, don't need to necessarily explain that. So let's talk about the last thing in the remaining time of our sort of flagship acquired or secondary immune deficiency, HIV. So HIV-1 and HIV-2 are two different lineages. HIV, from our best understanding, probably arose from a simian immunodeficiency virus and started mutating in the 1930s. It was found first in humans in 1959 in the Democratic Republic of Congo. Today, heterosexual activity is the #1 way that it's transferred. Other modes of transfer include blood transfusions, IV drug use, sexual intercourse, whether it's heterosexual or homosexual, and then also mother to fetal transfer. The HIV-1 and the HIV-2 designation refers to 2 different types of retroviruses. HIV-1 is the more common of the 2, mostly found in US, Europe, and Central Africa. And then HIV-2 is found commonly in West Africa. This is a retrovirus that uses its own reverse transcriptase to manufacture DNA from its RNA genome. It's covered by this lipid envelope, and it has the virus core in the center. It has an extremely high mutation rate. That's why it causes us so many problems in trying to come up with a cure or a vaccine, if you will. I'm not an expert on HIV, okay? But one thing that I learned in reading is this interesting fact that I'm going to kind of end with as we wind up today. So the cell that's target to be infected is the CD4 positive T cell. So it targets the immune system and the central nervous system, but you hear more about the immune system issues. If we look at the CD4 positive T cell, what the virus does is it actually binds to the CD4 using this GP120 protein. This GP120 protein binds to the CD4 cell. Eventually, through a conformational change and penetrating the membrane, it introduces its core virus. But in order to bind, it actually requires a receptor here, a CCR5 receptor. There's actually some patients in our population that are defective for CCR5. They've been exposed to the virus, and they do not get infected because they lack the CCR5 receptor. So it's obviously a very popular area of research right now on that CCR5 receptor. In the central nervous system, the problems are usually AIDS in the future, and it leads to dementia problems in these patients. So you don't see central nervous system disorders early on. So as the disease progresses, just have 2 slides to finish with. You get acute infection, where you get the virus in the blood. It takes over the lymph node. It spreads throughout the body, which is called viremia. You start manufacturing antibodies, okay? And then those antibodies kind of stay dormant for a period of time in a provirus, and that's called clinical latency. And that can be months to years, to even a decade, as some patients have shown us. But once it comes out of clinical latency, you get this chronic infection that's all over the body. Lymphoid tissues, spleen, everywhere. So the last slide of importance that we're going to end on is this one. I'm in dim lights because this is an important slide for you to see. A lot going on here, but what determines when you start seeing issues? You got CD4 positive T cell population on this axis, time on this axis, and then the copies of the virus on this axis. So the blue dotted lines are your CD4 positive T cells that have this death curve. And in this phase right here, it could be in this graph, it's showing you to be almost 8 years long. You have clinical latency, where you're losing a population of CD4 positive T cells, and you guys know what those helper T cells do now. But it isn't until they get to a certain cliff or tipping point, and the number of copies of the virus starts taking over. And as these guys drop, your immune system becomes compromised, okay? And you enter into this phase of human immunodeficiency virus rather than acquired immunodeficiency syndrome, which is AIDS versus HIV. And HIV is where you start having opportunistic diseases take over. I mean, most, unfortunately, our HIV patients don't necessarily die from HIV. They die because HIV drops the population of helper T cells, and other things like pneumonia, okay, cancer, dementia, other things come in opportunistically and take over the organs. Okay?